Hey everybody, in this video we're going to be going over end-of-life care. We're going to be talking about the symptoms that occur towards imminent death. We're going to be discussing legal documents and ethical issues that help patients and their families decide how treatment is withdrawn or administered during imminent death. We're going to be discussing the care of patients and their family members physiologically, psychologically, and spiritually. We're going to be going over interventions for different periods of imminent death, and we're going to be looking at things like the stages of grief and appropriate post-mortem care. So the first thing I want to go over are some of the common signs of impending death. These can be referred to as signs of decline or signs of distress. There are 7 that we are responsible for being able to recognize and understand. The first and probably the most common is going to be pain. Patients experiencing pain at times of impending death are usually the result of prior complications, and it is probably the most directly intervened against. In addition, many patients will experience anxiety or depression as a sign of distress and impending death. I think that there is that sense of self-awareness that starts to frighten them. That's another thing we need to be aware of. Additionally, patients can experience delirium, and what is meant by that is that patients will actually kind of go against those signs of decline and be alert, restless, and sociable, which can be a little distressing to family members because it's just such a drastic difference in how they were before. Anorexia is also a pretty telltale sign of impending death, especially looking at all of the other ones with it. When patients start declining meals, that voluntary stoppage of eating and drinking, that can be a sign of decline and distress. Impaired secretions is one of the last signs of impending death. It occurs in one of the latest stages of dying. Depression, mentioned with anxiety, just part of those self-awareness complications that patients experience. And dyspnea is also a very common and can be very challenging sign of distress to manage. Dyspnea is identified as a characteristic of struggling to breathe. There may not necessarily be an objective thing that causes the dyspnea, but the patient states that they are struggling to breathe. And that's something we need to understand, recognize, and know how to treat. Next, I want to discuss some ethical and legal challenges with end-of-life care. These are the 4 major things we are responsible for knowing and understanding. The major thing being advance directives. If you remember, these are legal documents that the individual or the patient signs stating, this is what I want to happen to me in the event I'm no longer able to competently request care. So if they say, I want you to discontinue any life-prolonging care in their advance directive, and they get to a point where they're non-responsive, then that has to be respected. It is legally attached to the patient, and it is above everything else. Now, physician's orders refer to what is known are physician's orders for life-sustaining treatment, POLST, PULST, and that is a form that I'm just going to read the definition. That's a form that translates patient preferences expressed in advance directives to medical orders that are transferable across settings and readily available to all healthcare providers, including emergency personnel. So this can infer preferences to CPR and intubation, artificial nutrition, hydration, and this is signed by the patient or a surrogate as well as a provider, and that can be an APRN, the attending physician, or a primary care physician, and a physician's assistant. So this is also something that is written in advance, but is with the consideration of the PCP to translate those preferences to other situations. For instance, if you are in a significantly dangerous and car accident, you sustain life-threatening injury, and you have pulsed, then that's going to translate to the emergency service personnel that are assisting you what your medical preferences are. And that can go into advanced directives saying, maybe I don't want life-sustaining treatment in the event of a life-threatening injury. Assisted suicide is pretty much as it sounds. This is, as our professors mentioned, when a provider concocts a group of medications that will intentionally kill the patient, but the patient is the one who administers them. It's actually at the patient's voluntary and competent request that this can be done, but it's only legal in one state, Oregon. So that's what you need to know about assisted suicide. Euthanasia itself is actually just a term that means the process of ending one's life. Now, I saw two major categories of euthanasia, the first being active euthanasia, where a provider takes an active step to end the patient's life, most likely at the request. As far as I know, it is not legal anywhere. The American Nurses Association strictly prohibits any sort of practice of euthanasia. But it is at the patient's request that something be done to them to terminate their life. Voluntary euthanasia is something more like the patient is refusing medication or that voluntary refusal to eat or hydrate themselves. So these are just a few of the things that present ethical and legal challenges, and it's our responsibility as nurses to be aware of what these things mean and what our policies and what the laws surrounding them are. So I want to get into treating the different end-of-life symptoms, those signs of impending death that we discussed earlier. First and foremost, I want to talk about treating pain. While pain management is going to be something that we're going to see in many cases, it's no different and it's no less important with a patient at the end of their life. So I've separated into pharmacological interventions and non-pharmacological interventions. So looking at how we can add medications to assist in pain management, it is recommended to start with morphine orally. Morphine, obviously an opiate, but at that point in their life, those risks of tolerance and potentially addiction are so significantly low because we understand that what they're experiencing is a sign of impending death. As terrible as that sounds, we just need to understand that we don't need to worry about going too short on a dose. What only matters is getting that pain level down, increasing comfort, and making sure the patient is not in distress as much as possible. It's recommended to administer morphine sublingually if the patient can no longer swallow. And if morphine is no longer relieving pain adequately, it's recommended to switch to fentanyl. Something I want to point out is that fentanyl is remarkably strong when it comes to killing pain. The dose that you would give for fentanyl is 1,000 times smaller than you would give for oxycodone to get the same results. But if fentanyl is unavailable, it is recommended to use oxycodone for the pharmacological management of pain. Some non-pharmacological interventions that are suggested are massage, and as silly as that sounds, I actually just want to share a quick experience. Some nurses on my unit at HCA had a patient who was recovering from a near end-of-life experience, and that's what they did for about 15 minutes. They were helping him massage just some weak areas, some painful areas, and it just gave a therapeutic environment, gave the patient some interaction, some sociability, and just really helps distress. In addition, music therapy and aromatic therapy are also just great ways to kind of help support that pain management and alleviate anxiety and depression symptoms. So these are just things to be cognizant of, especially when it comes to administering these medications. I just want to reiterate because I think it is important to know that the situation at which we are administering these meds is unlike a normal pain management case. The only goal is the relief of pain and the minimization of distress. The next common symptom of impending death that I want to discuss is dyspnea. And I just want to reiterate, dyspnea is not as objective a symptom as some of the others. It is really the patient's awareness of uncomfortable breathing, which is what can make it so tricky to treat. So it's important that we understand where dyspnea can come from. So just some things I've marked down is that it can be related to the patient's terminal diagnosis or secondary to the terminal diagnosis. It can be related to the treatment of the terminal diagnosis, or it may have no relation at all to the terminal diagnosis. But what is important to understand is that the way you treat it needs to be relevant to where it could be coming from. So the primary pharmacological treatment for dyspnea are opioids, in other words, morphine. If you'll remember, this was one of our quiz questions, things that we can do for our patient to treat their dyspnea. The reason morphine is on this list is because a symptom of dyspnea, in a way, is air hunger. You'll see incredibly rapid respirations, and that's just it's a bit of a strange characterization. But morphine can reduce anxiety and change the perception on that air hunger and start to slow down their breathing and help them relax, which is what makes it such a good intervention. Bronchodilators can be recommended if the dyspnea is related to some sort of obstruction in the pulmonary system. You would actually use corticosteroids if the patient is experiencing bronchospasms. Diuretics could be recommended based on if there is a fluid overload and there's pulmonary distress related to that. And antibiotics can be used in the case of respiratory infection. So just to reiterate, it's really important to understand where the dyspnea can be coming from, and that's really going to be in relation to the other information you have about the patient, especially the terminal diagnosis. Because many of these things could be secondary to that diagnosis, or they could be a direct result of the current treatment or a part of that diagnosis itself. So we just need to be aware and be thinking critically when planning our care around this kind of stuff. Some non-pharmacological treatments. One that is always appropriate for this situation is using a Foley catheter. And the reason for this is because that infection is no longer really a concern. If they're dealing with this kind of stuff already, again, it's a sign of impending death. And our primary goal is just relieving the stress and making sure the patient is as comfortable as they possibly can be during this period of time. So a Foley catheter can help reduce fluid overload and fluid restriction, which makes it a good non-pharmacological intervention. Additionally, elevating the head of the bed, in other words, positioning, just making sure it's easy, like your patient can breathe as easily as possible, is absolutely necessary because it's a very simple thing to do that you can assign to anybody, and it does have direct results. You can put wet cloths on the patient's face. This could be in response to infection, fever, that kind of stuff. Supposedly it works. And limiting exertion too is very important. You don't want the patient getting up and moving around a whole bunch if they are experiencing this dyspnea, because it can have a direct result on their ability to do stuff. So you just want them in a relaxed state, being able to focus on their breathing, to slow it down, and to just kind of chill out. So those are just things to be aware of and interventions that can help with the treatment of dyspnea. The next end of life sign I want to talk about is weakness and anorexia. The reason that I'm putting these two together is because they're usually related to one another, and they kind of stem from a patient's loss in appetite. As they stop eating and drinking more frequently, they're going to begin to lose that muscle mass and strength. So it's important for us to begin to implement safety precautions to make sure that we're not adding to discomfort or putting the patient in any risk of further injury. So for that, bed rest is the easiest and most likely safety precaution that we're going to be implementing. And part of this intervention is actually being allowed to insert a Foley catheter for comfort and convenience, just because it is in that period where the patient is at the end of life. We're not expecting a recovery. We're not expecting to worry about managing a new infection. We just want to give the patient less reason to get out of bed, less reason to put exertion and strain on the body, and maximize their comfort. In addition, because of this loss of strength, we can expect to see dysphagia in these patients, and that's when we need to be aware that if a patient is no longer able to swallow, we should not force anything down if we're just unable to. And I think that's pretty common sense. We don't want to create any risk of asphyxiation because we don't want to accelerate death. I think that's very simple. When it comes to educating on this topic, I think it's really focused more on educating the patient's caregivers and family members. And one of the biggest reasons for this is because anorexia can lead to a drastic change in physical appearance of the patient, and that can be really uncomfortable and like concerning for family members. So what's important for us to do as patient advocates is to just let these family members know that this is an expected part of the end of life process, and a patient losing their appetite along the way is completely normal. So we need to make sure that we're educating that we're not going to be forcing any nutrition that a patient doesn't want, is retaining their autonomy, and we need to help them understand that even though they're not eating or drinking, that doesn't necessarily mean it's adding to their discomfort. For instance, forcing food into a patient who doesn't want to eat is going to cause bloating and gas. That's uncomfortable. And actually supporting terminal dehydration can stimulate endorphin release, which helps patients feel a sense of elevation and well-being. So those are just some things to be aware on. This is more of a secondary type of end-of-life symptom that doesn't require as direct pharmacological intervention as the ones before it, but there are a lot of factors that go into why this happens and how we need to treat it as caregivers. Another common end-of-life symptom that we want to be aware of and prepared to treat is delirium. The first thing to recognize is that delirium may not be the full extent of what the patient is experiencing. It could just be simple agitation from something reversible. So that's what we want to assess for. And that could be something like pain, which means we need to look into adequate pain management, fluid retention, constipation. There are things that are pretty quick to reverse that can remove that agitation and help the patient get comfortable. If reversible causes are ruled out, then we can move on to treating it as if it's delirium. The best pharmacological treatment for that are antipsychotic agents, just kind of helping the patient remove that restlessness, start to relax, and start to kind of get centered in on themselves. It's important to educate the family members that similar to weakness and anorexia, delirium is a pretty common end-of-life symptom. So if the patient begins to experience that, there's not a huge amount of reason for major distress, but it's just another one of those things that when they're put all together really indicate what the patient is about to experience and really gives us the opportunity to prepare family members who are there and the patient for what's to come. It is, in my opinion, it's a really special opportunity to be a guide for a patient experiencing something that there is hardly any guideline for, but it's just important that we take this very seriously because unfortunately, one way or another, I'm sure many of us will encounter it at some point. Back on topic though, music and aromatherapy are also very good to help. I've seen in many situations with palliative care patients, just having them on bed rest and taking a computer in the room or a speaker of some kind and just playing some natural sounds, a running river, ocean waves, birds chirping, just those kind of like serene and non-intrusive sounds really help patients settle in and center themselves, and it can really just maintain a much calmer situation and really reduce that discomfort. So it's just another thing to be aware of as caretakers and to be prepared to treat if they come up, and just continuing to be aware of the situation that they arise in and how we look at our interventions because of that context. As we begin to move into the psychological and spiritual and all of those other auxiliary things to look at when dealing with end of life, one thing I do want to touch on is grief. And grief is described as the feeling of great loss. And to differentiate that with mourning is how people express it. But grief is just what the feeling is. We understand that there are 5 cardinal stages of grief: denial, anger, bargaining, depression, and acceptance. But something I think is really important to take note is that these stages are not linear. Patients can jump from any one stage to any other, and so can family members as they're experiencing this loss. Even if a patient finds themselves in acceptance of the situation, or a family member finds themselves in acceptance of losing somebody they really care about, something can trigger a new grief experience and they can move right back into denial or anger. It's important to recognize what these stages look like. They're pretty self-explanatory. One I do want to just kind of explain a little bit is bargaining. And that's really when patients are in a state of desperation, or family members are in a state of desperation, saying things like, we will give anything if you can save our dad's mother's life. We'll give all that we own. We'll trade whatever it takes. Just kind of that is really more of a stage of desperation. Whatever the costs, whatever ends will reach the means that they want. But I just want to highlight on this because it is something that we need to be able to recognize as caretakers, because we're going to be seeing it in these situations, and that really determines how we need to behave as advocates and as sympathizers, because we need to be able to address what our patient's feeling, not minimize or kind of just derationalize a patient's or a family member's grief experience. Something I think is personally very important to giving a patient the treatment that they need during an end-of-life experience is being cognizant of their spiritual needs and preferences. This, in my opinion, is going to be the greatest application of our cultural competency as nurses and as people, because we will be experiencing patients from a inexplicably vast variety of backgrounds and belief systems. So it is absolutely our duty to make sure that the patient's needs in a time like this are met. One thing I want to point out is that a patient doesn't need to subscribe to a faith to experience existential dread that comes with end of life. These human beings are just naturally more aware of the world around us, and especially of ourselves. So it can be verbalized from a patient that they're afraid and they don't know what to expect. And it's really important that we, as the advocate and as the caretaker, give them options, give them comfort when they experience these things, because we're the ones who are there for them, and we have to just be ready to diminish that discomfort when necessary. I actually found in the book a quick list of questions for a spiritual assessment. So hopefully these will be useful to us. You can ask a patient questions such as, how is your spirit? Do you feel you're at peace? What to you gives meaning and purpose to your life? What are you hoping for? Is anything in particular worrying you? And are there things that you wish to do or need to do? Just if a patient's spiritual background is unclear, maybe you don't have a great understanding of that patient's preferences, it's always easy to just ask those open-ended questions, those clarifying questions that we're taught, to just get a better understanding in how you're going to approach that kind of thing. So that's why this is all that I wanted to visualize, that patient preferences matter the most. We need to make sure that we are being respectful to the things that they need, even going as far as to arrange additional intervention from someone more qualified in these experiences. That is perfectly fine. If you feel like you are just not capable of providing the spiritual comfort that the patient needs, whether that means that you don't follow the same faith, or you're just not comfortable going into those things, that is totally okay. But we want to make sure that the patient's needs are met. So just always something to consider, being cognizant of a patient's spiritual needs in a time like this. So now I want to move on into post-mortem care. Hopefully up until this point, all of the interventions that we've given a patient at their end-of-life experience have been effective in providing the patient with a comfortable and dignified death. One of the most important things is to not rush our responsibilities in this part of our position. You want to encourage and give the family members who are present time to be with the deceased. We want to make sure that we're there as sympathizers, as shoulders to lean on, as people who just want to be there and help, because they're going to be experiencing rushes of grief. They're going to be experiencing great actions of mourning, And we just want to make sure that we give them the space that they feel is necessary to say their goodbyes. If you've seen it before, it is a very emotionally moving experience. So I just want that to kind of be clarified, because it may eventually happen and it's something that is not difficult to witness, but I believe that it's something that we need to be prepared to assist with. When it's time for our role and the space is clear, we want to go in and follow our facility's policy on postmortem care. Not every place is going to be the same. At HCA, nurses and techs are responsible for removing any wound care dressings, IV insertions, tube feeds, and bathing the body to be prepared to be sent to the morgue. Not every place is going to be like that, though. Best practice is to shut off any drips, any tubes, and to leave things as they are if the policy is unknown, because there may be a group in the facility designated to that postmortem care. So you just want to be aware of what the policies of your facility are. And lastly, organ donation is an incredibly important thing to discuss with the patient and their family during the end-of-life process. If it's not already listed in the patient's advance directive, or it just hasn't been discussed with the patient, you want to give them an explanation of how organ donation happens, what can the patient be expected to donate, and of course it's absolutely up to them whether they participate in that or not. That is just another example of patient autonomy. We just want to make sure they're aware of this is an option for you if this is what you feel like you want to do at the time of your death, but the choice is up to you. And when it's time to bag them and tag them, you now know how to address the situation appropriately.